This episode is sponsored by PACS, the gold standard in emergency response bags. So when you're working under pressure, you need kit to be both dependable, tough and intuitive, and that's exactly what you get with PACS. Every bag is handcrafted by expert tailors who understand the demands of personal care, from the high-tech, skin-friendly and environmentally responsible materials to the cutting-edge welding process that reduces seams and makes cleaning easier. PACS absolutely puts performance first. They've partnered with 3M to make perfect reflective surfaces for better visibility, and bright grey interior makes finding kit effortless and fast, even in low light. With over 200 designs, PACS bags are made to suit your role, your needs and your environment. And thanks to their modular system, many bags work seamlessly together no matter the setup. PACS doesn't chase trends, their designs stay consistent, so once you know one, you know them all. And if your bag ever takes a beating, their in-house repair team will bring it back to life. PACS are built to perform, made to last. Learn more at pacs.bags.com or head to the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. This is episode 3 of our 3-part series on palliative and end-of-life care. And today's discussion is one where we're really going to explore that of the final few hours of the dying patient. So in previous episodes, we've explored indeed recognizing the principles of palliative care and indeed the complexities surrounding anticipatory planning. But in this episode, we're really going to focus on really indeed one of the most emotionally and clinically challenging parts of end-of-life care, that's of the last few hours and or minutes of the dying patient. So how do we recognize when someone is in the last hours or days of life? And indeed, what role do the ambulance clinicians play when they may be the first healthcare professionals to engage with the patient in a crisis? So from identifying signs of imminent death to supporting families through caregiver fatigue, or indeed in challenging circumstances. We're going to explore some of the common presentations, some of the most important aspects of anticipatory medications, and indeed the role of advanced care plans in the last hours or minutes of life. We're also going to unpack the reality of symptom management, terminal agitation, and indeed the unique challenges of breaking bad news with sensitivity and clarity. And finally, we're going to reflect on the cultural, religious, and emotional complexities of delivering end-of-life care in a multicultural city like London. So in this episode, it really is a candid and indeed compassionate look at what it means to provide dignified care in the last moments of life. So to do this, I have Karina Catley and Natalie Nabunya with us. Welcome both to the podcast.
Hello, hi, thanks for having us.
I wondered, Karina, I'll just get your thoughts first, and then Natalie, we'll come to yourself. But I guess really, just as an opener, really, could I get you to speak to recognition of the dying patient? Just maybe some top of mind things that you think about in recognizing the dying phase.
Yeah, absolutely. I think what I'd like to start off with is recognising ambulance clinicians' role in this, and absolutely, as you said at the beginning of the episode, about how actually a lot of the times we are the first clinicians to perhaps even recognise that this patient is in these final stages of life, and that could be for a number of reasons. Either the patient's not engaged with community services, or actually they've been kind of managing quite well at home and something's happened a little bit more suddenly, and therefore they've not had that interaction with people like the GP. But I suppose I'd kind of pass over to Natalie to talk about the signs and symptoms, because this is your bread and butter.
Yeah, thank you. I think the first thing we often need to remember and understand is we need to recognize that somebody is actually dying, that what we're seeing and what's in front of us is somebody sort of in the last stages of their lives, and that forms part of the bigger picture of the individualized care plan, which sort of goes back into the ambitions that we spoke about in the last episode. The signs and symptoms are in part of the last year of life. The signs, the symptoms that we discussed at that point in the last episode are quite similar. It would probably be, the more common presentations would be somebody who has taken to bed, so they're less mobile, they have a significant functional decline. At this point, they're probably unconscious, they're not able to respond to you or let you know what their needs are. They might have audible upper airway secretions, because as we start to enter the last stages of our lives, we tend to manage our secretions less well. I think people commonly might refer to that as the death rattle, for example. The individual might look quite pale, they'll be quite cool to touch, and that just sort of feeds back to the body just starting to shut down and concentrate on the more vital organs. But having also said this, as we're quite individual and we're quite unique in our day-to-day lives as people anyways, not everyone will present this way. But these would be the common signs that we'd expect to see. There's some people who we might term as dying on their feet. So these might be people who are actually alert, they might be walking up and down, moving up and down, and then maybe 2 hours later, they probably end up dying. We would probably still recognize that they would be in the last stages of their lives, but everyone's unique in terms of how things progress for them. I don't know if I
No, yeah, I think what I was going to come in and say was, as ambulance clinicians, I think we kind of, our routine is to come and do a set of observations on these patients, and that's absolutely something that needs to be done for a lot of these patients, especially if we are the first ones recognising that they're entering this stage. We may well do a first set of observations, and I suppose from that standpoint, what we often find is that they will present with things like low oxygen saturations. They will have an increased respiratory rate. They will often have a very low blood pressure, be quite hypotensive, and be tachycardic as well. And I suppose our reflection of that is if you look at that in isolation of a patient that looks very unwell with those observations, and you don't have that history that Natalie was talking about, you can very much jump to, oh, this patient's potentially septic, or there's something very wrong and they're very sick and we need to transport. So I think it's really key what Natalie was saying is it's building that whole bigger picture, and that history taking is really going to lead you to signs that this person's dying if they've been engaging less in family, talking less, taken to bed, those kind of ones, the typical ones.
Yeah.
I appreciate what you're saying. We always get those atypical ones where things happen very suddenly, but it's that history taking is so key, isn't it, to build that picture?
Yeah.
So just looking, before we really move on, absolutely, and like you said, just really dialing down into the history. Could I get you to speak to maybe Natalie and or Karina, just some anticipatory medications that clinicians might be atypical to clinicians actually, but actually maybe quite familiar to palliative or end of life care teams, just that actually might be regular attenders. So just something which indeed the patient might be on as an anticipatory medication, such as, I guess in a way, really high strength painkillers such as maybe fentanyl or otherwise, which is, really starting to offset some of those really chronic, now acute symptoms. Could I get you to speak to some of these medications?
Yeah, I think I'd probably talk about the more common medications that we might put into somebody's home. And we tend to do this preempting that somebody may be in the last stages of their life. Sometimes they're termed just in case medications as well. And we normally would only give them if they're necessary to give. So they would include, this would probably be the most common that you'd find in someone's home, would be an analgesic, such as morphine. That's to help with pain or breathlessness. We'd also put in something to help with anti-sickness. Most commonly, that's haloperidol. That can differ depending on the patient's history as well. So we need to always be mindful that we're thinking about what are their comorbidities as well before putting these medications in the home. There'll be a sedative, such as midazolam. This is often to help with things like agitation, for example. And the last medication that you might see would be glycopyrronium, which is to help with the secretion management. There are other drugs that we might put in place based off the patient's history, and that could be if we know somebody's on anti-epileptic medications, for example, we might want to put in an injectable form of that because we'd want to continue managing those symptoms at the end of life. but that is also very patient specific or case specific. And those particular medications wouldn't necessarily be known to the ambulance service. You know, they might have an idea of it, but they wouldn't necessarily be dealing with those particular medicines. But from a specialist palliative care background, we need to consider those medications if it's needed.
Yeah.
But I think with the ambulance service,
yeah, I think obviously we play a role in interacting with these medications, but absolutely we're not prescribing, and they're not familiar to us. A lot of ambulance clinicians, this will be the first time they're hearing of some of these medications. So I suppose our role is, if these injectables, these anticipatory meds are in the person's home, depending on what trust and service you work for, a lot of paramedics can give these subcutaneously as and when required. I think a really important point is to recognise that these may well be in the house, but actually the patient might not need them. We know the research shows that a lot of patients towards the end of life do experience one or more of these symptoms, but actually you do often, I suppose, Natalie, you can talk to it, you do get these patients that don't require anything. They're there just in case, as Natalie said, but we might not need them. And I suppose a point that I think is important to make is that it's not always specialist palliative care that prescribe these, and actually the GP, certainly in the UK, should have kind of sole responsibility to prescribe these, and they come with a medication authorization chart, a medication administration and authorization chart, and that's something that the ambulance clinician should be quite familiar with and be able to read and be able to document what kind of medications they're giving. And I suppose my tip as well is recognizing that we're not familiar with these drugs, is always share the decision before giving these medications. So we know medication errors can occur in these kind of high stress, emotional environments. So that's something that we try to promote in our services. If you're not confident with giving these, not familiar with these drugs, is just doing your normal drug checks, but also sense check it with someone that knows the patient as well. But yeah, absolutely, there's a role for ambulance clinicians, because we're going to get called to these patients when they're dying, and when there's some sort of crisis, if they're having a pain crisis or breathlessness, we're going to be the ones that the family, the carers tend to call.
Yeah, absolutely. No, absolutely. And one of the aspects of the symptomatology that I recognized was just around noisy breathing, actually, and nothing more complex than, an elevated respiratory rate. But to Natalie's point, that might have been a feature for a while, but when that breathing becomes a lot more irregular and or noisy, even as you were saying before, even in younger patients with palliative and or end of life care, in the dying phase, when there is a raised respiratory rate, and then maybe really in the last few moments, the respiratory rate starts to lessen and lessen and lessen, and that for me was a really acute sign, actually. Natalie, as you're saying, there's a lot of baseline observations which have clearly deviated for a long time, but that respiratory rate, elevation of the respiratory rate, and then almost a subsistence, and as it starts to lessen and lessen, really for me was a tangible, okay, this really, we are really in the last moments of life. And I don't know if that's been an anecdotal reflection or indeed experience of both of you, but that those respiratory changes being quite an acute marker, really.
Yeah, I probably should have been a bit more clear initially, but absolutely, breathing can be very distressing, especially for family or people who are watching, and it can present in a multitude of ways. There can be tachypnea, so high respiratory rate, but equally there could be a much slower respiratory rate with apneic pauses in between, and those pauses can be quite prolonged, they can be quite short, and that can fluctuate throughout. And equally, the noisy breathing, the upper airway secretions, that tends to be significantly distressing for family, because we've all heard it, and it definitely can sound like somebody is struggling to get air in, and it's one of the most basic things is breathing, isn't it? And for an individual who doesn't have a medical background, hearing that, it can be very distressing, but oftentimes it's quite important to look at the individual in front of you and try establish, are they in any discomfort? Are they showing any signs of distress, such as frowning? Are they groaning? And sometimes in those cases, actually, they're quite comfortable, even though the secretion, that the noisy breathing is present. We just find that sometimes the secretions sit quite higher up, and can be quite difficult to manage. But actually, it is not causing distress, and it's important in those moments to reassure the family at that point in time that we can give something for this, but it's unlikely that it will help. But in some cases, it might. But also to sort of support them with their fears and their concerns, and just try and manage that, and explain to them, this is what we can do, but this is what might continue to happen. But absolutely, breathing can be very distressing. And I think that's probably one of the reasons family might call for an ambulance, actually, is their breathing has changed.
Yeah, I think that's a key one, is either they've got so they're in distress, the breathing's changed, or actually they're becoming more unconscious and less responsive. And that's often where we get called in to these kind of situations.
Yes.
Yeah, it kind of leads me quite nicely on to the next question, actually. Just around carer acopia, or just the feeling of not being able to cope, just through it, like you said, through the longevity of days, nights, weekends, and just this really emotive period, really, for family members and primary carers. Could I get you to both speak to, really, indeed, Karina, maybe yourself, and then Natalie, around just some of the reasons why we get called to patients in the end of life and stages of care, and indeed, just, yeah, you've mentioned already just this, the change in breathing, the change in conscious level, the family distress, sometimes denial, which again is extremely difficult. Could I get to speak to these presentations? I'd love to hear both of your thoughts, actually. Karina, to you first.
Yeah, I suppose my experience and from working in the service and having all these debriefs with our clinicians about it is absolutely the family will call when there is that sudden acute changing condition, like we talked about, the unconscious or some kind of uncontrolled symptoms coming up, and if it's 3 a.m, they know they're going to get a response from us, as opposed to any other service. We're going to get there the quickest. I think in terms of the kind of family distress or carer kind of breakdown area, I think what I've recognised, or what my experience is that you can prepare a family as much as you want, but actually the reality of their loved one there dying in the home in front of them is a very different reality. And actually, I think it's all well and good and absolutely important to make these plans and know what your loved one wants. But if you don't have that care support structure at home, or actually it's too distressing for that family, then that's when perhaps we get called as an ambulance service and we need to be looking at the other options. And I think we can sometimes think, oh no, that's not what the patient wanted. But actually, if the family's not coping and they're not going to get the care they need at home, that's then when we need to start looking at other options. But I suppose, Natalie, this is absolutely your area. What's been your experience?
I mean, I'll probably say the same thing. I think what people don't realize is the emotional burden of looking after somebody who is actually dying. And it's also thinking about the finality of death. I think a lot of people are very much on board and saying, yes, I'll look after my loved one at home. But when reality starts to kick in, the picture starts to change. The amount of probably physical labor that they might need to support their family member with, or the emotional burden, all sort of comes to head. And yes, that's when they might call for emergency services, just because there's probably nowhere to turn. And sometimes it might just be that they needed somebody to come and tell them, actually, you're doing the correct thing. And maybe that might settle their fears. But sometimes, as Karina said, maybe we really need to think about, is this the right place for this person to stay? Have we managed or put all the support in place that is possible to put in the home setting for this person, to help them keep their loved one at home, if that was the loved one's wish? But equally, then we might need to think about, do they need to go somewhere else? Do we need to consider a hospice? Do we need to consider hospital, depending on the urgency of the situation? But then equally, we need to think about the journey. Is that journey moving this patient to to another area,
Yeah.
will that be distressing for them? So it can be quite difficult situations to manage, but I think it really does boil down to what Karina has also just said, in terms of people don't understand what they're in for until they're facing it, and then the reality of death hits them, and then the grief is already starting before somebody's died. Yeah.
I think communication there's key. I think once we recognise that a patient's in that dying phase, it's about, and I know we're going to be talking about communication a bit later, but I suppose it's about managing expectations and explaining the process of death in a way that families can understand and know what to expect and what's happening next. And that can help inform them about a decision of, okay, can I cope with this? Do I need more care support at home? And then figuring out how we can support that.
Yeah, absolutely. I couldn't agree more, actually. And that communication piece, we'll go there in a short while. But just before we move on, really, to maybe some of the absolute fundamental challenges when supporting patients in the final weeks or days of life, could I, before we go there, could I just get you to speak to terminal agitation? Because I think sometimes, like we said, the respiratory rate is one thing, conscious level is another. And to your point, to both of your points, really, about the distress of seeing an agitated patient, actually, like you said, it fundamentally probably hypoxic in a way, and just that hypoxic agitation, really, which is acute confusion, chronic to acute confusion, but overlaid with the hypoxia, and is maybe, like you said, just the last few sensors within the brain, the respiratory centers sort of really shutting down, and that, to your point, Karina, really about, I guess, in a way, bringing the family along, that this is normal, this will happen. They are becoming a bit more confused or agitated. It's something which is to be expected, and then kind of aligning expectations there. Natalie, could I get you to speak to that?
Yeah. Terminal agitation is very distressing. We've probably seen it quite a few times ourselves. And it can present in a multitude of ways. I think Karina and I actually this morning were just talking about, sometimes people live how they die, and there are people who are quite busy, people who were mobile, who walked around, who kept themselves very busy. Sometimes that might emulate in their last hours of life, where they're trying to get out of bed, they're trying to reach out. And I think sometimes the issue with this particular scenario is family think that I can talk to them, we can calm them down, but in reality, you can't calm them down. You need support from a healthcare professional to manage this particular situation, and that tends to add to more so to their distress when they see their family in distress. When there's a picture of, I think we all have an idea that we'll fall asleep and die. And a lot of people want that for their loved ones. And so for them to see somebody so agitated, screaming out, trying to get out of the bed, trying to mobilize, with whatever last energy that they've got, they're trying to, get somewhere, not listening to their family, that can have such a strong impact on the family's grief following that, or that they just have that guilt or that sense of, I didn't look after them the way they wanted to be looked after in their last days of life. So it can be a very distressing picture, and this is oftentimes where probably the ambulance service comes in a little bit, just because they respond slightly quicker, probably, to a palliative care team, where they're quite helpful in terms of managing this particular situation. And obviously, if this is a patient that unfortunately is not known locally to the palliative care or to a GP service, that picture can also add to more confusion and to more distress, and it's just trying to figure out how best do we manage the situation. But terminal agitation,
it's a really tricky one, isn't it? I suppose how I always saw it, and it's really interesting hearing Natalie, your view about the extreme of where they're trying to get out of the bed and scream. And when I think terminal agitation, I think of a patient that's conscious but not kind of getting out of the bed and just picking at the bed sheets, which is obviously a lot easier to manage than someone that you're describing. And I think my reflections on how we would manage that as an ambulance service is obviously it's lovely if they've got anticipatory meds and they've got that midazolam in there for agitation. What I've learned is really key is communication with the family before you give that midazolam, and actually explaining to them that once I give this midazolam, this isn't going to hasten death in any way, but actually because we're relaxing them so much, the thing that's keeping them awake at the moment is that agitation. Once I give this midazolam, they may well not wake up again. They may go unconscious, and then that their body's so relaxed, then it may allow them to die. So I think that's really important to communicate that with the family, because that is the last time potentially, if it is real, true kind of end stage terminal agitation, that's the last time they might get a chance to say things to their family member while they're alert. So even though they're not fully aware, that's the word, absolutely. So that's kind of my key learning. And I suppose also, I know this is the context of the dying patient, it's also making sure your history is suggesting that, and they're not having like delirium, which is absolutely treatable and isn't a terminal event and there's many reasons for delirium, which is another episode, but it's putting it into context of the whole of the rest of the history is suggesting terminal agitation as opposed to delirium.
And that's a very good point, because it equally, I've also had situations where I believe it's terminal agitation, but equally this might be somebody who has quite end-stage dementia and is very confused. And that picture can be very confusing to a healthcare professional. And it's, should I sedate this person? Is it appropriate to sedate them? And I guess that goes back to the shared decision-making, the history checking, making sure what you're seeing in front of you is this or
is there a cause? Have they got constipation, urinary retention? Have they got a pressure sore that's causing all of this? It's really, really tricky area, but shared decision making, absolutely. I would always, if I'm thinking of giving midazolam, I would always sense check that, because we don't just want to be sedating people when they're in pain or distress for another cause.
Could be another reason.
Yeah, listen, I totally agree with absolutely both of what you're saying, and let's go there really, because there's more to the conversation around, like you said, reversibility versus the dying patient. And I think that's to your point, Karina, and to yourself, Natalie. It's really, I think that shared decision making is absolutely fundamental, because it's such a crucial decision. Is, do we, like we said, offset and or mitigate some of the symptomatology, or do we directly treat? Is it a low blood sugar? Are they hypoglycemic? And actually that's treatable. We should treat it, versus sedation and or expediting just the sedation just to give someone a death. So there is, like you said, there's reversible causes, and there's maybe understanding this is the true organic nature of metastatic multi-organ cancer, which is actually taking hold of the body and actually probably shouldn't be reversed. And actually, and I might be opening a can of worms here, but it's actually, I'd be interested to know, reversing, a profound dose of morphine, it might not be the best thing to do, because actually if that morphine is there for a reason to mitigate pain, and there is some semblance of pinpoint pupils, or there's a semblance that the patient's still alive, but in a really sedated place, actually understanding that maybe those opiates are there for a reason, and not reversing an opiate, a strong opiate medication, because it's doing a job for mitigating a whole cadre of painful symptoms. And I guess to your underlying fundamental point, and you both said this, it's share before you step forward with any medication. The more I think you're in practice, the more you realize your fallibility, and sharing these decisions, saying, look, we've got A, should I do B, C, or D, and understanding that and sharing that. But could I get you to both just speak to the appropriation, reversibility versus non-reversibility? I think the MDT approach, multidisciplinary team approach, is key. Bringing the family along, as you said, is key, but also, I guess in a way, understanding, like you said before, Natalie, the trajectory of care. Could I just throw it out to you, and then we'll kind of move on?
That's a big question, isn't it? And it's something I think we always debate and struggle with within the ambulance service, because it is the conundrum. We call it the conundrum. I guess my initial reflection, I'm going to hand over to Natalie to talk about the opioid toxicity point that you brought up, is absolutely it's looking at the history, it's looking at that person as a whole, and it's thinking about, is this a likely cause of that disease progression? So we know, for example, patients with advanced dementia, the main mode of death is aspiration pneumonia. We know that is, you're not dying of the dementia, you're dying as a result of the causes that the dementia does, and how that affects. And we know a lot of mode of death for these people will be infections as well. So I think the biggest debate we have is sepsis versus dying. And the question that comes up is, can it be reversed? Which anything can potentially be reversed. Cardiac arrest can be reversed. But the key question that we, I think, put on ourselves too much is, should it be reversed? And actually, that's not a decision that an ambulance clinician that has just met this patient should ever be making in silo. And that's why we really, really push this MDT approach, this shared decision making, because that is one of the most difficult, I think it is the most difficult call for an ambulance clinician to make, is, what are we going to treat and take this patient, or are we going to go down that dying route? We don't have a simple answer for that, other than what you've just summarised, is shared decision making, speak to the family, getting that really good history and that context. But yeah, they're my initial reflections. I don't know if you want to come in, Natalie.
No, I agree. It's very difficult, and it's very case specific. I think you need to know what the environment you're in is presenting you with, and what information. So unfortunately, there's no clear answer that I can give anyone, or we can give anyone, about what decision you're going to make at then at the time. I think in relation to opioid toxicity and reversing that, equally, that is also very case specific. I don't want to sit here and say that we've never reversed an opioid toxicity. I think in palliative care, we generally look at respiratory rate and saturations. Sometimes pinpoint pupils don't always give us the most clearest answer that somebody is toxic necessarily, until we notice that respiratory depression and low saturations. Those are the times that probably we might action. But that equally is a very difficult decision, and that often, or all the time, needs a more senior oversight, because as you said already, you don't want to reverse something where you've given it to treat something, and you know that the fact that you're going to reverse it will cause more distress and discomfort. It's just going back to what Karina said, it's important to involve the family in those kind of situations as well, to explain, this is what's happening, this is what we're planning on doing, or who we're going to talk to about what we do next. But yes, reversibility, as Karina said, there's always something to reverse. If you look very hard for it, you will find it.
Yeah, that's the problem.
That's the thing.
And I think, yeah, we do, aren't we? As ambulance clinicians and paramedics, we want to help and reverse, but it's that should we reverse question, exactly. And that's when we involve other people in that decision.
Yes,
that knows the patient. Yeah.
But I think just because you mentioned diabetes, I will just highlight that there is a national guidance on diabetes at end of life and in the management of that in the last days of life. So anyone can access it with a quick Google search, just to inform yourself, just to give you a bit of understanding around that specifically. Just because it was mentioned, I thought I'd...
No, fantastic. No, actually, Natalie, we'll put that in the show notes. I'll link that in the show notes, because I think that'd be super useful for people to, as a resource, to go away and read. Absolutely. Yeah, absolutely. So let's go there with breaking bad news. So the eventuality of and the fruition of time has taken place, and the patient has died. But could I get you to both speak to really some key principles and or lessons learned around breaking bad news to the family in these situations? Indeed, Natalie or Karina.
Yeah, I mean, breaking bad news, I think it's also, scenario specific. There's some people who will be very much like, tell it to me bluntly, or others where you think, actually, I need to take my time with this. I think you need to assess the situation. You need to judge the person you're speaking with. You need to know the environment you're in terms of when when you're trying to deliver such news. I think it's important. I think we'll probably get to sort of the cultural aspects of things, but it's important to understand the dynamic of that family that you're speaking to. I think my advice for people would be to be very honest and to be very clear in what you're saying. We tend to shy away from very hard-hitting words, I think, as generally as humans. So you often find that people will say things like they've passed away, And I think in my role as palliative care, I think it's important to be very clear and say, your loved one has died. I think the impact of that word and the finality of that word sort of delivers the message that you're intending to communicate. So I think it's important to be very honest and be very clear in what you're saying. No jargon, no sort of beating around the bush. Making sure who you're speaking to, you understand the person that you're speaking to, because people, how they receive information, it's very different. So it's a lot of work on us as healthcare professionals in terms of trying to understand the environment you're in and how do I deliver this news. There's obviously advanced communications, learning tools that people can access just to help them. I think it would be quite long for us to go through a lot of the frameworks or the types of scenarios you could use, but I think some of them probably you as ambulance services do have.
Yeah, I think that there's so many tools out there, isn't there? But I suppose my key thing is you'll pick up phrases throughout your career that sit well with you, that you see other people do, and having a bank of those is always quite handy, because I think I suppose the anxiety for healthcare professionals is we don't want to be delivering this news, and I think we sometimes put that anxiety on the other person as well. And actually, this isn't our bad news to receive. We need to be doing as good of a job as we can to not impact on that patient's grief journey. My tips, alongside what Natalie said, absolutely, about using clear language, is to provide a bit of a warning shot that bad news is coming. I think if we go straight in with so-and-so's dying or has died, that can, even though we see that reality in front of us and we think it's really obvious, it might not be to that family. So having a bank of phrases like, I've got some bad news, do you want to sit down, do you want someone else with you, do you want to go to a different room? If you say things like that, people kind of get the sense that something is not good news, is it? And it can be helpful, depending on the situation, to ask what the person's understanding of what's going on, and that can help you gauge if that family is kind of rooted in reality, and actually you think, okay, I can probably speed this process up, or actually if they're completely maybe oblivious or in denial of what's going on, then you think, okay, I'm going to have to, like Natalie says, be really careful and do this in bite-sized chunks for them to bring them along to actually the reality of what's happening. But yeah, like Natalie says, it's really situation specific. There's so many different tools. We use Ask, Tell, Ask in London Ambulance Services, but there's so many different tools that you can use. I think you've got to find your own approach and just consider things like if you're delivering it over the phone, if the patient's safe, not driving, in a safe space to receive that information, and confirming that they are the right person to have this information, that they are known to the patient, they are next to kin.
But generally you find people will know. They might not show that they know. They might act oblivious because there's that element of, I don't want this to be the truth, or the denial. But generally I found people know. They know what's happening. That they just might not want, they're not ready to face it, or they might not want to face it. But equally, they are definitely people who this is a shock and it's new to them. And
I think you've got to give it a go and be open to trying it, and you can always apologize if you get it wrong. I think that's really important. I think we're so worried. We're worried about how we're going to deliver it, but actually they're still going to be receiving the worst news of their life. We can do everything we can to try and make that land as well as it can, but it's not, you might well do it absolutely beautiful job and the patient, the family members completely blow up in your face about it, but that would always have happened. So don't take that anxiety off you a little bit. Apologize if you stumble and get your foot in your mouth, because we all do it sometimes.
Yeah.
Just be open to apologising, but
Yeah.
you need to take that anxiety off you, that the reality is they need to know, and that could allow them those final moments with that family member, or start that grief journey as well as they can.
Absolutely.
Yeah, listen, that completely resonates with me. I think what we do is put in the show notes the Ask Tell Ask tool, just so people can go away and look at that. Like you said, there's multiple tools, and people will understand what works for them. Just as we come into land on the conversation, really, one final topic really is something which I became accustomed to, which is, just the adages, and indeed the benefits, but the exposure that London gives, really. That a big multicultural city, almost 10 million people, just could I get you to both speak to, and Natalie, maybe first, just the cultural considerations when caring for someone in their final stages of life with family? It's such a multicultural melting pot in London, and in a way, clinicians are foisted into these situations, as we were saying before, every time of day and night, maybe at the fourth night shift at 2 a.m. But it doesn't detract from the gravity of the situation. Natalie, could I get you to speak to that?
Yes. I think it's such a wonderful thing to live in London and to be part of this melting pot and experience different cultures. But equally with that comes the difficulty of not knowing how necessary to support these families. And I think what maybe might help us a little bit is based off where we're all based, the areas that we cover, is trying to understand sort of the immediate families or the cultures that make up that particular area. I think the considerations that you need to understand, I probably mentioned it a bit earlier on, is in some families it might be, the men that are head of the house, and maybe that's the person you need to talk to. Or you can't talk about death and dying in the home, because that's not allowed as part of their culture background or their religious background. And it's important that I think, and we're probably coming to learn this a little bit more, but it's important to understand, what home am I entering into? How best can I talk about this situation to them? How is it best to deliver it? Do I need to speak to maybe their spiritual elder, for example? Is that the best person who can deliver this information? It's about trying to understand those kind of aspects, because that will impact how you care for that patient, is liaising with the family. And so I think being open-minded is so important, because how we do it one way does not necessarily mean that that's how it will work for everyone else. And that's why I think I just say, know the community that you're serving, try and get a bit of understanding of who makes up this community. Because for some people, it just might be, linking in maybe with a mosque, for example, speaking to an imam, just saying, how can I support your community better in terms of these situations? And they might give us the most practical steps around it. And I think recently we've just had a little talk about sort of supporting people at the end of life or care after death, which I think has given us a little bit of insight ourselves, even me as a palliative care nurse, just about the options that are available and what we can offer these families or these patients when it comes to considerations for their culture at the end of life.
Yeah, I think it's, I suppose I can talk to some of those kind of examples on some of those situations ambulance clinicians have found themselves in, which they've perhaps not felt comfortable with. But I think I totally echo Natalie's point about it's a person-centered approach. Just because someone is Muslim or Jewish doesn't mean they're going to necessarily follow the general principles, and it is a very individualized approach, as you said. I suppose some of the challenges when caring for a dying patient, and then I'll kind of move on to care after death, but with the dying patient, I think what we've found is certain cultures are very much of the mindset that God will decide when this person is to die, and that can make it challenging, I suppose, sometimes when we're talking about perhaps not treating this infection or not giving oxygen when that person is in that dying phase, and trying to explain how that is not going to benefit that patient and the risks involved in that as well. So that can make those conversations challenging, and we do need to be culturally sensitive in those options. And I would say normally a palliative care team, if there are those complexities, are involved, and absolutely we should be using them for communication as well. And another, I suppose, a challenge is when it comes to delivering anticipatory meds, because some cultures or beliefs, or even we had recently one patient and family who went down the complete alternative medicine route and were in complete denial about this person's terminal diagnosis, and that can make it really challenging to deliver these medications when it seems appropriate. And there's a fear, I think, even culturally, amongst many cultures, that these are going to hasten death as well. So again, it's all around communication, isn't it, and involving specialist teams to help give the best care for these patients. And in terms of care after death, we like Natalie said, we had Dying Matters Week recently, and the whole theme was around culture of dying, and we had some really interesting talks and conversations around this area. And one particular scenario I can think of is a family that had strong Christian beliefs, strong Christian faith, and they wanted the deceased to stay at home for a number of days while people came and visited and paid their respects. And that sat really uncomfortably with the ambulance clinicians, because it's a request they'd never had before when they came to verify the death. So I suppose our learning from that was to, as Natalie said, be really open-minded, absolutely seek advice if you're unsure about those sorts of things, but don't just shut down those conversations because it feels uncomfortable for you. There's always a way we can facilitate it in some form. But yeah, I suppose those are my reflections around culture.
And I think probably the most common one I think we left out was language barriers.
Yes, yeah.
Just communication. Again, it goes back to communication, but making sure that we're delivering that communication in a language that somebody else understands. And just be mindful not to use family sometimes for these particular conversations, because you won't know how that message is being translated, for example. So
yeah, make use of our translation services where they're
available. Yeah.
Indeed. And actually, just to your point, just as we finish off, and just to get you both to speak to this, really, something you both just mentioned is around signposting, because the unique aspect of pre-hospital care is that, like you said before, you're there for the finality, or indeed the last chapter of life, the last half an hour, maybe 2 hours. But actually, it is a moment in time, and you're not there for the longevity of grief. You're not there for the longevity of processing, because, like we said, we've got maybe other patients to attend, or indeed other, the shift might be finishing. But so actually, and you said this, which is super important, this signposting, that actually there is people that can journey with their family on that grief journey, far beyond that moment in time, and giving, I guess, in a way, the family a access to services where there is a bereavement counselor, or just someone that can actually process the grief over time. I always felt it was super difficult, removing yourself from a highly emotive scene where, like you said, expected or unexpected, it's still sometimes is the worst day of someone's life, and sort of removing yourself from that, thinking, I'm really not sure they're going to be okay. And actually, bringing, even just calling relatives, saying, look, you need to come around now, just to be with this, to be with the relative, because they shouldn't be on their own in this situation. We need some community here, and that might mitigate the next few hours, 6 hours, 12 hours, and actually having services to signpost for the next 24, 48 weeks, months, years even, so that there can be some kind of continuity of care over time, outside of that short consultation that you're there for.
Yeah, I'll probably start by saying, firstly, I think I mentioned it in the last episode, that it's important that we look after people at the time of death the way they were looked after in their time of life or in their time of illness. A good life lived needs equally a good death. And having said that, I think it's important that we remember how the care we've provided will impact the grief of the family members. I think we need to be mindful of how we speak, how we support and care for the body after death, it lasts a long time in the memory of family members who think actually they were looked after so well, and actually that can mitigate some of their grief. But there are obviously charities available. I think the first normal thing that we would often say is contact your GP, because I think it's important that your GP is aware that you've had a bereavement in the family. Should there be anything that, further distresses that particular family member, at least the GP is aware that this is why that's being precipitated. Contact your GP, who will be able to liaise with other services such as talking therapies if that's what's needed. But in terms of specific signposting, there are very many. One comes off the top of my head is Good Grief that you can contact as an individual. But there's a multitude of services available to offer support. But I think what I tend to push first is your GP, because the impact of bereavement can manifest in different ways. And oftentimes I think it's good that they have oversight of their patient, who's the family member.
Yeah, and I guess from an ambulance clinician perspective, we'd be doing that anyway to inform them about either this patient's actively dying or have died. I guess it's important to consider that actually grief is a normal process as well, and where we are there when it is so acute, of course we're going to see that emotional outpouring, but not everyone will necessarily need that support long term. And I think, correct me if I'm wrong, Natalie, but I think hospices that have bereavement services, they don't tend to link in with family members till at least a couple of weeks, if not a month after. And that's to allow that natural grieving process to occur. And there's not one way to grieve, everyone does it differently. But I think there are things like complicated grief disorder, which absolutely, if we're going to a patient as an ambulance service that has lost someone, and we're going to them time and time again, or we visit them and think, they're really struggling here, that's absolutely something that needs addressing. But I suppose my reflection is it's a normal grief process, and it's great to have those signposting, but people need to go through it as well. It's a healthy, normal, natural part of life as well.
And also if they're quite religious, they have their spiritual elders, or
the community.
There's many people that they can access if they need to talk it through. But as Karina said, it is just a part of life as well.
Yeah, indeed, and I'll put links to Good Grief in the show notes, actually, Natalie, because I think it's useful. Like you said, I think the first pivot to both of your points is to make sure the GP is informed, and then the next pivot is to understand, like you said, the continuity of counselling and or services that might be available to talk and process things through. Absolutely, I think that's powerful. Listen, thank you to both of you. And I just want to extend my thanks to the wider team, actually, because it's fantastic just to get a 3-part episode together where we've just really gone through that patient journey and just tap into both of your expertise, the wider team's expertise, actually, to really discern, understand, unpick, but also just define some of these transitions in the patient journey, in end of life and palliative care, and actually demystifying some of this, because it is challenging. It can be extremely poignant. It was definitely struck me in a really challenging way on a number of occasions. So I just want to thank both of you, actually, because it's been super powerful just to really lift the lid on this really challenging aspect of pre-hospital care.
Thanks so much for having us. We've really enjoyed it. Thank you.
Thank you so much, and even for allowing us to have the platform to talk about these things, especially following Dying Matters Awareness Week, which was last week. So it's a very important topic. Thank you.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.